Welcome. We're very happy that you're joining us today for our session on refractory suffering. Are we starting at about, Okay, so we are going to start. There may be some people joining us late, but I'm Jessica Miller, and I am a professor of philosophy at the University of Maine, and I'm happen to be chairing the sociology department this year, don't ask. But for many years, and I know several of you, I was clinical ethicist at Eastern Maine Medical Center for about 15 years. So thank you for joining us and my esteemed colleagues.
I am Sue Belanger. I'm the Senior Vice President for Mission and the System Ethicist at Covenant Health. Have been doing this for, ethics at least for about 20 years, but I don't know all the answers. And also I look through, and you'll see that I look through all of this through the lens of the nurse, because that is my primary socialization.
Thank you. My name is Frank Chessa. I'm Director of Clinical Ethics at Maine Medical Center, an assistant professor of medicine at Tufts University, do a lot of teaching of medical students, and it is nice to see everybody, some who I know and some new faces. So without further ado, we have an exciting program for you today.
Okay, can you hear me okay? Is the mic picking up? Okay. So I'm going to be introducing the topic with a more philosophical and less practical bent, but I think sometimes it's nice to take a few minutes and maybe think in a different way. At least I hope it is nice for you. So I'm going to, without further ado, talk a little bit philosophically for a minute. So as we know, relief of suffering is central to the mission of palliative care and hospice. The World Health Organization, defines it as improving a patient's life through the prevention and relief of suffering. We know Eric Cassell is one of the intellectual forefathers of palliative care. He actually died about a year ago in his 90s, physician and bioethicist, and in his 1985 book, The Nature of Suffering, he defined suffering, he said, suffering is experienced by persons, not merely by bodies, and has its source in challenges that threaten the intactness of the person as a complex social and psychological entity. Suffering can be defined as the state of severe distress associated with events that threaten the intactness of a person. So I think what Cassell really helped distinguish things like pain, like if you're talking about childbirth, very painful, but his definition of suffering wouldn't necessarily call that suffering, because the pain of childbirth in most cases doesn't threaten the personhood, the intactness, the integrity of a person, the way that severe suffering, particularly at the end of life or with chronic illness, can do. So the Oxford Textbook of Palliative Medicine defines suffering as an aversive experience characterized by the perception of personal distress that is generated by adverse factors that undermine the quality of life. They include 4 areas of potential distress that are amenable to therapeutic interventions. First, pain and other physical symptoms like nausea, fatigue, vomiting, constipation. Second, psychological factors like anxiety, depression, confusion, insomnia, as well as factors that might adversely influence those disorders, physical symptoms, feelings of hopelessness, lack of perceived support, strained relationships. Third, existential or spiritual issues, the view that life may be without meaning, death, anxiety, disappointment. And fourth, family and caregiver distress, resulting from the anticipated loss from being witness to the patient's distress or from the burden of care. I know you're all very familiar with the various checklists and identifying, where the distress is coming from, where the suffering is coming from. But I'd like to shift a little bit. Before I shift, I'm going to unshift. It's worth noting that this is a very functional approach, and it's very important. But it rests on the ideal of a patient. There is an ideal embedded within it, who is enabled to die in peace because both their physical symptoms and all other elements of their suffering are under full medical control. All deviations from this ideal are seen as defects. And I think we might want to ask ourselves what that means. Refractory suffering is suffering, definitionally, it's due to symptoms that cannot be controlled despite state-of-the-art medical or palliative care. It seems relatively rare based on a literature review that I did, although there are relatively few cases, they have an outsized impact on providers. And I know that my colleagues will talk a little bit more about that. Now, I think if we remove the definition of state-of-the-art palliative care, there's probably a lot more refractory suffering because people don't have state-of-the-art palliative care necessarily. But I certainly think it's worth asking what it means for you as a caregiver or as a medical professional to deviate from this ideal that you have as a professional or as a caregiver. What does it mean for the patient to deviate from the ideal of what the death is supposed to be like or how my suffering is supposed to be mitigated? The very word refractory means resisting control or authority, stubborn, unmanageable. Think about that in relation to the stated goal of palliative and hospice care. About what refraction means, deflecting from a straight path, something that needs correcting. What does it mean to think of a patient's symptoms that way? What reflection does it cast on you as a professional? So I'd like to shift the frame a little bit from the distress thermometer approach that we saw in the earlier slide to think more holistically for a minute. As Cassell once said, we think a sick person is just a well person with a sickness. The same person you've always been, but you happen to have a sickness. That isn't true, he said. And building on his definition, there's a ton of work on this actually in Sweden, in the Netherlands, in Northern Europe, because of changes in their laws that have to do with aid in dying. So this guy, Frederic Svenaeus, is somebody who's been doing some interesting work on it. He says, building on Cassell, he's a Swedish philosopher, suffering is a potentially alienating mood overcoming the person and engaging her in a struggle to remain at home in the face of loss of meaning and purpose in life. It involves painful experiences at different levels that are connected through the suffering mood. So the levels are embodiment, engagement with the world and others, and core life values. So most basically, a biological life is at stake. It's a necessary condition for everything else in life, is the biological life. The illness and its effects may also endanger the patient as the subject of the story of their own life, the main character of the story of their own life. The illness and its effects may endanger the patient by making it difficult or impossible to go on contributing to the things that give meaning to life and that give coherence to the story. Perhaps even more fundamentally, it can endanger them as a person having their own life to live at all by invading their daily routines and corroding intimate relationships. They may feel they're no longer their normal self in other social contexts because they're losing the essential elements that determine their role and status in those contexts. The person they feel they are, the person we think we are, is who we are as reflected back to us by our social context. So in all these respects, there's a disparity between what you're accustomed to do and be and what you find yourself able to do and be now. And the structure of the world actually changes in physical suffering. It's not just the person, it's the structure of their life world. They perceive things around them in new ways, and you can think of an example of the difference between seeing or smelling a delicious meal when you are very hungry in contrast to when you're feeling nauseous and sick, right? Or think about how a beam of sunlight can catch your attention when you're shivering with cold in contrast to when you're having a migraine. That beam of sunlight shows up very differently for you. So reflecting on Cassell's theme of how suffering threatens integrity and Svenaeus's theme of suffering as a mood that colors everything, perhaps we can think of palliative care and hospice work as bringing the patient home. As you all, I'm sure, know well, the Latin word hospitium initially meant the warm feeling between a host and a guest, and was later expanded where this feeling was home and coming home, came to mean that. They're powerful, powerful words in English. Home can mean one's house or home-like environment, one's own body, the psychosocial environment, or the spiritual dimension. Obviously, with respect to a home or home-like environment, home is a place where a patient can feel more autonomy, control, safety, comfort, and connection. Our bodies are both things we are, and our bodies are things we have. We can feel at home in our bodies, and we can feel alienated from our bodies. Helping a patient feel at home in their bodies is one of the main goals of palliative care and hospice care. The psychosocial sense of feeling at home is the experience of taking part in sharing one's life with other human beings. And here, psychological well-being is at issue. And finally, and the morning keynote was really wonderfully expounded on this, spiritual and existential beliefs refer to the way people find meaning, purpose, and value in their lives. And these issues, as you know well, become very urgent for people who are near the end of life. Home is also associated with the place where we originate. Coming home is a journey back to one's roots, a journey in which the past, the roots, and the future, the journey, are interwoven. Human life is, quote, a being towards death, as Martin Heidegger put it in Being and Time. And you know, Jim Van Kirk is doing a competing event, but he tells this joke. Have you heard Jim Van Kirk's joke about what's the sexually transmitted terminal disease, human life? So he's like channeling Martin Heidegger, a famous German 20th century existential philosopher there. But for all of us, death is the horizon, right? So death is the end of one's existence in one's own house, in one's body, and in one's psychological environment. Therefore, while dying means leaving home and going on a solitary journey to nowhere land, it also means coming home. Home is a concept familiar to us all, the sick and the well. Caregivers can ask themselves, what can I contribute to make the patient feel at home in these different ways? By taking care of a patient's safe coming home, the caregiver can help the patient to live and to complete a good life. Suffering patients live in a world different than they know, and since we co-create our world as we live in it, they are different selves than they know. Suffering patients, it is important to be sensitive to the world in which they live as it is, even if this means recognizing highly disquieting facts for what they are. This was a big theme of the keynote first thing this morning. Reflection, discussion, support, and consolation are also an important part of palliation. The Latin root word is palliate, or cloaked. And palliation does have a role of muffling or cloaking some of those negative symptoms like pain. Right? But thinking of palliation as coming home expands suffering and our concept of it beyond a checklist of symptoms to cloak, to include an understanding of the patient's suffering in all of the senses that we've mentioned so far. That quote, palliative care is the umbrella, not the rain. I have the citation here that was published in JAMA Oncology earlier, it's a good article, earlier this year. And if you'd like the slides, I'm happy to share. So with that, I think we will turn to our next.
Great. So we were kind of trying to figure out how to organize the session, and I got the part of the session has to do with a tangible case. So I'm going to present a case where there was refractory suffering, and I'll talk about how we responded to that case, and get a reaction from you a little bit later on whether that was an ethical approach to refractory suffering in the case I'm going to talk about. I think it'll be really interesting to take some of the kind of metaphors and the sort of linguistic ideas that Jessica, and see how if we can apply them to this case. So the patient we'll call Philip. He's 17 years old. He has Ewing sarcoma. At the time we meet him, his cancer is widely metastatic, with some particularly large tumors in and around the lungs. So he has difficulty breathing. He has bone pain. The primary site of the tumor was in his leg bones, in his femur. And there's bone pain. He was diagnosed when he was 13 years old, and had a sort of really gung-ho, I'm going to fight this cancer since that time. So he's worked really hard with his primary oncologist to beat the cancer. But now when we meet him at 17, he's lost weight. The last attempt at palliative chemotherapy sent his blood cell counts down, so he's neutropenic. And essentially, even a light dose of palliative chemo sort of tipped him over. So he's pretty close to death. So Philip has two parents involved in his care. Family lives together. He has two younger siblings. He has lots of high school friends. And so it's a pretty rough time, both on the emotional level. And then on the physical suffering level, the shortness of breath was very difficult to handle, even with opioids. The bone pain, similarly, very difficult to handle with opioids. So he had a good deal of physical pain and physical symptoms as well. So this gentleman sat down with his primary oncologist one day, and he said, Doctor, you've asked me to do a lot in the last 4 years, and I've done everything I possibly can. You know, I've changed my diet. I've gone through chemo a million times. I've been here in the hospital, radiation. You know, I've done a lot for you. I want you to do one thing for me, and that's I would like you to kill me, which is really quite tough to hear. So the doc, the oncologist said, in a longer conversation, but that isn't something that I can do for you right now. However, one thing we can do for you is to use palliative sedation to unconsciousness. So our opioids are not really being successful at treating your refractory pain. We've gone up and up and up. You're not opiate naive. There doesn't seem to be a way we can do it. So we'll give you some medications that will induce unconsciousness. You're pretty close to death now, so within a couple of weeks for sure, you will be unconscious, and that course will move forward, and you'll pass away. There won't be a feeding tube during that time. Patients taking food by mouth now, we are not going to insert a feeding tube and feed during that process. And so it was tough. He's 17, so his parents really are the decision makers. His mom had a hard time saying yes to this, but ultimately she was in the hospital. We met with her over a couple of days, and she was like, I'll do what Philip wants to do. Dad was almost incapacitated with grief, had a really difficult time coming to the hospital, and remained quiet on whether he would support this plan or not. And I can fill you in, but that's sort of at the point we were deciding. So some of this gentleman's high school friends came in, they said goodbye. His younger siblings came in and said goodbye, and so we moved forward with palliative sedation to unconsciousness. His dad kind of, through some telephone calls, did not object to the plan at the end of the day. So, but a very tough approach. This happened years ago. It was maybe the first time my institution did palliative sedation to unconsciousness. Tough because it was a minor. So the consent process was a little bit, how does that work? And I think the toughest thing for lots of us, both the family and the clinicians, was the idea that this timing is very clear. You're going to turn the drugs on, and the person is going to lose consciousness. And I know nowadays we tend to wake up periodically, but this was a while ago. The idea was we'd turn the drugs on, and that would just be the last time you would be consciousness. So similar to when you're terminally extubating a patient, you're in control of the timing. And being in control of the timing felt, I think, pretty strange and weird to clinicians involved. So that's the case to present. Kind of a sad one, but one of the practices that's around nowadays that people use to respond to refractory suffering.
We're going to talk a little bit now about some of the ethical issues that might arise in the use of specifically palliative sedation, since that was kind of what I looked at. Although I will tell you that the ethical issues that we'll talk about really are ethical issues at the end of life in lots of different situations, not just in the situation of palliative sedation, and you'll see what I'm talking about here in a minute. So I want to really describe some ethical challenges from the perspective of providers, from nurses, and the teams in the situation of refractory suffering and the administration of palliative sedation. Also, I want to talk a little bit about two important aspects of moral distress, which we'll talk about right after that, and then really opportunities to build team resilience, which, one of the things that we talked about either yesterday or today was this idea of having to build that resilience, because it's really important that we continue to do this work, and without resilience, it's really hard to do this. So when I looked at the literature around palliative sedation, at least from the provider perspective, there was a sense that providers tend to want to treat the physical symptoms, and the psychological, existential ones seem harder to put their fingers on. And so when it comes time to making those decisions, and I think we actually heard this morning a conversation about, is it really existential suffering, psychological suffering? Or, and some physicians in the study refused to do palliative sedation until there were some physical symptoms. So that existential suffering of its own was not really enough for some clinicians. Now, I'm going to preface all of that by saying in the situations where it seemed clear, it was a really good option and it was a choice that clinicians agreed upon. So we're talking about the ethical challenges of the sometimes these are the things that happen, okay? The other is this idea of not everyone has or not everyone feels comfortable in psychosocial or psychological assessment or support. And so there's a difficulty then in trying to really know for sure, when is this really existential suffering? Like, at what point does that really happen? Did it come before? Did it happen during all the treatment? Is it as a result of the treatment? Where in this continuum, and does that make a difference? So those were some of the challenges. Also, clinicians had some difficulty with really trying to relieve suffering and then saying at the very end, okay, we're just going to let this all go and do this palliative sedation. It's sometimes difficult for clinicians to let it go, right? So what we know is we try really hard to alleviate suffering, and if we can't do it. Sometimes that's the right answer, but for some clinicians, it didn't always feel as that was the right answer for them. And then also there were challenges in the literature, and I also hear this from people who work in this particular area, this idea of what is symptom relief and what is hastening death. And I will tell you, when we talk about ethics, we talk about what's your intention, right? What's your intention in the act? If your intention in the act is to alleviate suffering, but that the unintended or the foreseen event, which is called the principle of double effect, right? The foreseen outcome is the likelihood that someone could die, because this could be the last dose of medication you give. Then the intention of symptom relief is the right intention. If, however, your intention is hastening death, then ethically we would say that might be a problem, right? Depending on what area that you're working in. If you're working in aid in dying, and that's a different kind of approach to end of life, that would be a little bit different. Also, providers had some ambivalence and difficulties in clinical decision-making when it wasn't really clear that the patient had this type of suffering. For nurses, it was a little bit different, but there were some similarities. Nurses felt uncomfortable with palliative sedation when they weren't really sure that was really what the patient wanted. In the case that Dr. Chessa just talked about, the patient was like, yeah, I want this. Okay, so that's clear. Clear when a patient says that. Not always clear when families perhaps haven't had enough conversation with the patient. And what you'll see here a little bit further is that sometimes patients, families, clinicians were not always on the same page around some of this information or some of what we know. And so it can create some ethical issues for the clinicians and for nurses. Another thing where nurses appreciate so lots of the literature said nurses were really good or felt a little bit more comfortable. I'm not going to say really good. Felt a little more comfortable with psychosocial care of patients, psychological care of patients. In particular, hospice, community nurses. And they felt uncomfortable when they could no longer talk to the patient. So when you put a patient in a state of sedation, and now you can't figure out whether or not this is really what they want now that they're in this state, there was this sense that this doesn't feel completely good for me, right? This doesn't completely feel right. Also, the idea of refractoriness. Is that clear? Is there a clear definition of what refractory psychological or existential angst is? There were some concerns about that. So again, physical versus existential symptoms was also a challenge for nurses. And for nurses, often for the palliative sedation, if there was a lack of a clinical guidelines, nurses often were like, yeah, I don't think this is something I can do. And so, we'll talk a little bit more about some of that, like how to help the team members in this process, because if nurses are feeling uncomfortable, they don't understand the ethical implications of the work that they're doing, they're going to turn over much more quickly, right? They're going to walk away from the scenario going, I can't do this work because I just don't feel I'm doing the right thing. And so what have we done to help train nurses? Do we provide them guidelines? Do we provide them enough education so that they can do this work and feel comfortable in this work that they're doing? A lack of respect for nurse opinions or team dynamics. Some of that was nurses tend not to speak up about what they know about patients in some situations. Sometimes the power of the group, there's the power dynamics of the group, may preclude nurses from speaking up. Every voice is very important in this process, and I know from some of my colleagues that they ask all the questions and want information from everyone and solicit opinions from the entire team. But if that's a problem in your particular environment, it's something you probably want to take a look at. The beliefs of nurses came up as an ethical challenge. Some felt that palliative sedation did not, in fact, relieve distress. Does that really do what it's supposed to do? Palliative sedation is euthanasia. Again, that's, worthy of some conversation, right? So if your team members are not clear about what the role of palliative sedation is, then it's absolutely important to do some ethics education. And then post-sedation concerns about what was the real cause of death here? Was it the underlying condition, or was it the fact that they had the sedation and they didn't eat for a number of days, and did we starve them to death? And then again, also the importance of the family's ability to communicate. If that is lost, that sometimes nurses saw that as an ethical issue. In terms of team challenges or team dynamics, the powerlessness of the team and their inability to articulate that they're unable to relieve suffering. That was huge in this literature. It really was important for teams to sit and talk about that, so that you all sort of understand how each other feels about these challenges that you're facing with particularly complex patients, families, situations. Also, the unrecognized mutual suffering, which was seen in physical signs of distress and feelings of impotence and failure, and also philosophical differences. One of the interesting ideas that came out of the literature was the idea that how people think about a particular situation. So I think this morning's conversation with Dr. Van Kirk, when he was talking about, did I do the right thing? What about my colleagues? And what did they think? I think those are important conversations to really be able to say together, did we do the right thing here? And how did we all think about that? So that we're all understanding one another's perspectives in terms of how we're treating patients in these complex situations. Having actually ineffective communication was a challenge. I think it's a challenge in every end-of-life situation, whether you're in a hospital, whether you're in a hospice and palliative care. Just ineffective communication doesn't benefit the team, does not benefit the patients or the families. And once you identify what those challenges are, that you've got to really talk about it and make some improvements there, because that's critical, right, to the work that you all do. Again, for physical versus existential suffering, it's like, that's a challenge. That really is. Palliative sedation is a challenge in terms of the existential suffering. So keep talking about that. A united front. So I've been working in end-of-life ethical challenges for a very long time. And united front and everybody being on the same page is probably one of the key issues that we find in ethical challenges. Because we've got to all be saying the same thing to families and patients, because then a family member will pick up something that someone will say that's not exactly the right thing, and they will run with that. And they'll be like, well, Dr. So-and-so, or this person so-and-so said this. And then you have an entire communication challenge with families and patients. And so, again, it's a huge challenge that we all face, and it's really important for all of you as team members to be united in the care of your patients. Honest team discussions. I don't think there's much more to say about that. Soliciting honesty, creating safe space for honest conversation is really, really important. And I will tell you, it's really difficult right now to have safe space because there's no time, right? So we have to create that time. We have to create that space. We have to create the moment. We have to allow ourselves the opportunity to hear the voices of everyone who has to be heard in this process. Again, unaligned goals of care, clinicians, patients, families. We see it all the time. The family wants this, the patient wants that, the team is recommending this. How do we get everyone on the same page? I was at an ethics committee meeting yesterday, and one of the clinicians said, we offered the family hospice, but they're not sure they want to go that route yet. How long is enough time before they decide? I was like, ooh, let's all take a deep breath. Let's give the family some time. This is not an easy decision, but yet, as clinicians, I think sometimes we see the end point. We see that trajectory going to someplace really bad, and we want to put them in hospice really quick, but those families are not ready for that yet. They're not in that space to make that particular decision. We need to be kind and a little bit more generous in terms of how we see that situation for them. Philosophical alignment around treatment goals and personal philosophies. We need to recognize our own feelings in a clinical encounter, because how we go into that particular encounter could affect how we interact with the patients and the families, and I think that's really important to consider. And then cure versus care. So it turns out that in the literature, there's a sense that we've moved from the original philosophical approach of hospice to more of we shifted a little bit more to the curative side, a little bit more emphasis on the medical model and less of an emphasis on the psychosocial model that was originally intended for hospice care. And so one of the things to consider now is how do we get back to the original intention of hospice and palliative care, right? And then this idea of clinicians seem to have insufficient skills, and I think they talked about the folks with multi-skills, right? The chaplain social workers, how they really enhance the environment. And yet, when we have experts and we send patients to our experts, it alleviates some of the stress on the one clinician, right? You want to refer somebody to someone else because it's this is hugely burdensome, so I'm going to send this person over to the psychiatrist, or I'm going to send it over to the other expert. And then in that process, sometimes clinicians feel they're losing their skills to be able to do the work well. And so think about that as you tend to transfer patients to the experts. Does that have an impact on your own expertise as a clinician, that you're not feeling like you're as competent as you might have been in this process? Okay, so I want to talk a little bit about the results of all these things, right? All this tends to result in something called moral distress. So moral distress is the situation of psychological distress, being in a situation in when one is constrained from acting on what one knows to be right. So that was Andrew Jameson, who did that in the 1980s or something, was the originator of this moral distress. And what is recent is that moral distress is moving into this started as a nursing phenomenon, but it tends to be moving into other disciplines. Other disciplines are feeling the same kind of thing. So when we think about moral distress, it's a distress from causing pain or continuing the suffering of. Think about like not alleviating pain, or constraints from the healthcare organizations, and I heard a bunch of those today. We don't have enough staff, we don't have enough money, we don't have the right clinicians, we don't have resources in Jackman, Maine, that kind of thing, right? Some of those constraints. And then also changing global therapeutic perspectives. When you think about what's happening in the Netherlands, or you think about what's happening in Belgium, and you think about like where the policies kind of are coming from in Europe, and you think, well, maybe we're not kind of ready for some of those things. And so some of that may be causing some distress. In another article I read, there are 2 conditions to be met for considering something moral distress. You have an experience of a moral event, and then also it causes that psychological distress. So lastly, I just want to talk a little bit about, there's this great article that in an initiative that was started by Cinda Rushton, if you know her from Hopkins. She does a lot of work in resilience. And they pulled a number of people together really to talk about that. And some of the things that came out of that I thought were probably going to be helpful for some of you if you're thinking about it here. But to build systems to support ethical practice. Are you having conversations about this? Is there a way for someone to raise an ethical issue in your particular facility or your group or your particular area? To educate the public about the things that are particularly problematic for you. So one of the things that we do in ethics often is when you keep getting a consult on the same problem, then you do something to address that problem. So what are the ethical challenges that you're facing? Then put some resources towards that to see if you can make that better. Proactively identify and address any issues that may trigger conflicts. This was really evident for us in terms of benefit when we started to put someone who was on the ethics committee in our ICU rounds. So that person would go from room to room listening to what was going on, and then would raise the ethical issue if she heard something. And that was really beneficial because the team started to think about anticipating those ethical issues before they came up, before they became problematic. Also to take a look at the benchmarks, right? Are you turning over a lot of people? Are people like, yeah, I can't do this work anymore? So I actually teach graduate nurses, and the nurses that I've seen in the last probably 6 semesters were COVID nurses, right? And they're like, yeah, I'm leaving the bedside and I'm gonna become a nurse practitioner. Like, yikes. We've got to make sure that you work through all the distress that you've all been dealing with, because how then will you be good providers for, your patients moving forward? And because COVID has created a lot of angst and moral distress for new nurses. Develop practice guidelines to address those areas of concern. And then lastly, really think about ethics training for your leaders and your boards and the people who allocate the money for the work that you do, and who allocate the resources for the work that you do, because, might really be helpful to help them understand the challenges that you are dealing with so that they can provide you some additional resources. So references, and then any questions we will answer as a team. So the question is, for those who have existential suffering, who have identified that, has it been offered to stop eating and drinking?
Sure. Folks in the audience know that sort of one of the topics that's getting a lot of attention in the ethics literature in the last few years is voluntary stopping of eating and drinking. And so the question about voluntary stopping eating of drinking is, do you allow it?
I mean, it seems that palliative sedation, I'm a hospice social worker, palliative sedation for folks who experience physical symptoms, right, that are more commonly seen in our practice. However, when someone is experiencing what we would coin as existential distress, palliative sedation may not be the right option. And so then, would it be recommended, or do you commonly see cessation of eating and drinking in lieu of use before palliative sedation?
Right. And so the question is, would you offer it? So I think as we look across the country, we see practice changing here. I think it used to be, and maybe it still is in the setting where I work, if a patient comes forward and says, I'm thinking of voluntarily stopping eating and drinking, there's an openness to that among palliative care clinicians. Some of the hospices I work with will not immediately admit a patient. They will wait until that process moves down the road a little bit, and there are symptoms and the patient's closer to death before they admit the patient. I think that's going to change. I think there's more discussion in the public about voluntary stopping eating and drinking. So I think it's sort of being brought up by patients and families more often. And I think that's going to kind of move the field. This is all my impression from the reading. But I think it's going to move the field a little bit to thinking about a more proactive offering it as an option. There's a new book out, which is really kind of the radical cutting edge, are we ever going to go there? And that's voluntary stopping of eating and drinking. A bit of a misnomer, but after somebody loses capacity on the basis of an advance directive. So folks with dementia who want to take control of the end of their life don't have medical assistance in dying as a possibility because you have to have contemporaneous capacity to do that. So there's a kind of movement to say, well, in my advance directive, I'm going to refuse oral feeding when I reach a certain stage of my dementia, and I want the memory care facility or whoever's taking care of me to stop feeding me orally at that time. So I think that's the next debate in this field.
So we have a number of post-acute facilities in my health system, and that is something that when there's a patient that's admitted with dementia, that conversation is had before the patient loses capacity to make that decision. So that's that area. However, someone who has not had this conversation with this family can create some angst in the family because food is love, right? So when we have an emotional connection to food, like food is love, and now we're saying grandma does not want to eat or drink anymore, that creates some family angst as well and can create some family suffering. So it requires some really good conversation again and some work with the chaplains and the families and the social workers to really help the families kind of understand the approach that the patient may be taking in that particular situation. It's, what I've learned as an ethicist is nothing is ever black and white. There's a whole lot of gray. We live in the gray a lot. And much of the gray is really about communicating preferences, communicating why, communicating intention, all of those kinds of things, so that families really can be on board with the person who's making that particular decision.
Can you speak a little bit about the difference between medical aid in dying and palliative sedation from an ethical perspective?
Well, I think Susan said something earlier when she talked about the doctrine of double effect. And I think when we are talking about palliative sedation, we're palliating symptoms.
I guess the specific aspect is that the palliative sedation is administered by a professional, and the medical aid in dying requires the person to be able to self-administer. And so that kind of seems like, distinction that's important, but ethically, how does palliative sedation get past self-administration?
Okay, so the question is the difference between physician or medically assisted death, where, I know there's a lot of different terms, and in Canada, medical aid in dying means something very specific that it doesn't mean here, for example. But I think what we have, what's legal in Maine, right, is for someone to ingest something voluntarily, whereas in palliative sedation, it's being, right, but the purpose of the two acts is different. And I think that's what Susan was talking about with her intention. So ethically, we can distinguish them even if their end result is the same, death. Yes. It seems a little slippery to some people, for sure.
Yeah, and there's a lot here. So this is like one of those fun things we could talk about for a long time. But there's voluntary active euthanasia, and you can think of that as there is a clinician causing death with a death-causing agent. There's medical assistance in dying, which is the patient is causing their death by ingesting something. This is kind of a classic way of thinking about the distinction. And then palliative sedation to unconsciousness is not thought of as there's an agent directly causing death. The thought is still you're providing an agent that induces unconsciousness with the intention of alleviating suffering. Death still occurs because of the disease process, not because you've provided drugs that intentionally induce unconsciousness, or that not because you provided drugs that induce unconsciousness. The thought is that the pathway towards death is still being driven by the disease process, not by the actions you're doing to palliate symptoms.
It does seem like a very fine line to draw to a lot of people. Yeah. Like an article I read had the statement, are we eliminating the suffering by eliminating the sufferer in palliative sedation? So that, I don't see it that way, but I think these are important questions to air and not pretend that they don't exist. But I think we probably...
But as a provider, that difference is huge for me. I do not want to voluntarily end a patient's life, and yet I have been with many patients who have been suffering both existential and physical, and I don't have any qualms about giving them medication to provide comfort. And that is critically important in my core, to know what is my intention at the bedside of this patient administering this medication. Am I there to relieve this patient's suffering, or am I there to end this life? And so whether it's the nurse or the doctor or whomever is at the bedside, I think that's critically important for them, for that person, to have a good handle on what am I doing here? And in what manner am I doing it? Am I administering this drug to just get this over with and slamming it home as fast as I can? Or am I giving this medication in a responsible fashion to alleviate suffering and then allow the natural process to occur? So I think for the provider who's actually there, it's a huge difference.
And it matters legally too, because one thing is legal in Maine and one isn't, right? Right. I think it's 2:03. I want to thank everyone for being here, and I hope that you enjoy the rest of your afternoon.